Hello everyone and welcome to today's webinar. I'm just going to give a couple of minutes for people that are just joining to make sure they're on the right page with us. And we're really pleased you're able to join us today where we are going to be discussing how to maintain healthy skin around the laryngectomy stoma. I think when we think about our patients and using base plates and adhesives, we often think about the size and shape of the stoma. We think about how sticky we need the adhesive to be. But do we pay enough attention to what the skin under the adhesive looks like? And that's what we're going to be talking about today. We're going to have go into detail of the science of how the surface of the skin works, how wearing a medical adhesive on that skin can interact with our skin. And we're going to present the details of a white paper that Atos Global published at the end of last year. And we're also going to introduce to you a brand new skin assessment and management tool that we've created here in the UK with the aim of easing diagnosis and management of laryngectomy skin conditions in the clinic setting. So just a few introductions. If someone could move on to the next slide for me, I can't get it to scroll forward. So my name is Claire Rodd and I am the Head of Clinical Education at Atos UK and I'm a speech and language therapist by background. And I'm really pleased to be joined by two of my fabulous colleagues today. We've got Faye Remisser, who's a Senior Clinical Educator in Laryngectomy at Atos UK, and she is also a speech and language therapist by background. And then we've got Jess Hurrell, who's our Interim Head of Nursing here at Atos UK and a Head Neck Nurse by background. Could you move on to the next slide, please? Just a few formalities and housekeeping notes to go through with you before we get started. Now, this is our first time using our exciting new webinar platform, GoTo. You might all have thought it looked a bit different when you were joining today, and so do please bear with us if we have any technical glitches, such as the fact I can't move the slides on. But please do take a bit of time to just get used to the slightly different tabs around the screen. And at the top of your screen, there is a tab called Active Cameras, and you might want to click on the little arrow next to that and move where our presenter faces are to the side, just to make sure you've got full view of the screen in front of you. For everybody in the audience, your cameras and microphones will be off for the webinar. If you want to chat to us and if you want to put any questions forward for the question and answer session at the end, please use the little tab that's got a question mark in it. The chat function on GoTo is only for organisers to give you messages, so you won't be able to chat on that function, I'm afraid. And then I just quickly need to go through our disclaimer. So Atos Medical provides a forum to facilitate discussions and questions. Nothing in this session provides any diagnosis, clinical advice, guide, warranty or guarantee. Nothing in this webinar can substitute individual advice or guidance from a qualified healthcare professional, and Atos Medical does not suggest, imply or make any claims other than those detailed in the product manual. Next slide, please. So on to today's agenda in a bit more detail. So we're initially going to talk about medical adhesive-related skin injuries, which is abbreviated as MARSI. We're going to go through how adhesives are made up, what's the technology behind our adhesives, structure and function of the skin, how we might categorize MARSI, how we can minimize it, then talk through the new skin assessment and management tool and finish off with some time for questions and discussions. Before I hand over to Faye, we're just going to run a couple of quick polls just to get a bit of an idea of who's in the room listening and what your background knowledge is on the skin. So I'm just launching the first poll now. I hope you can see, just to get an idea of whether we've got speech and language therapists, nurses, or other professionals on the webinar today. Great. So I'm just going to share those results. We've got 50% speechies, 28% nurses, and other 4 people, 22%. And then the next poll I'm going to launch now. So this is thinking about how you would rate your confidence in assessing and managing laryngectomy skin conditions. Do you feel a bit confident, not confident at all, or you feel that you're pretty knowledgeable already on skin conditions? Just give another couple of minutes for people to make their votes. And a bit of a split there, but 53% of you feeling sort of in the middle, that you do know a bit about skin, but hopefully we'll be able to leave you feeling really confident at the end of the webinar. And then the final poll is just thinking about how you might typically manage a patient who comes into clinic to see you, perhaps for a voice prosthesis change, and you notice when you remove their adhesive that they've got a reddened skin area around their stoma. Do you think that's just what we expect for patients that need to wear an adhesive on their skin? Would you consider changing them from a base plate or an adhesive to a larytubal button? Do you go through with the patient how they are removing the adhesive and what their application techniques are? Or do you think about referring them to a tissue viability nurse or dermatology? Great, and 92% would review adhesive application and removal technique. So Jess will fill us in with her wisdom as we go through the webinar on what she feels is the best way to manage a patient's skin. So I'm going to close that poll and hand over to Faye to kick us off about medical adhesive related skin injuries. Thanks, Faye.
No problem. Welcome, everybody. So thanks for that, Claire. What we're going to do now is take a look in a little bit more detail about medical adhesive-related skin injuries. So in 2015, Atos Medical commissioned a qualitative research project to gather information about the challenges that patients face with a total laryngectomy. And they found that skin health issues related to two main factors: irritation caused by prolonged wear of adhesives and also stomal topography. And as we can see here from the two cases, Eva found an adhesive that fit her stoma shape, but obviously irritated her skin with the prolonged use, whereas John was unable to find an adhesive that would stick to the skin due to the poor fit, and that would lead to a lack of seal, and then the base plate would blow. So for our total laryngectomies, wearing a base plate is the most popular method of housing a HME. And what we know from the evidence is that use of intratracheal devices, like larytubes or buttons, can cause problems to the stoma. So for example, they may have increased levels of irritation that may then lead to swelling and stenosis. It might lead to crust formation or maybe even difficulty in clearing secretions, and that could lead to an obstruction. Air escape around the larytubes can also impact on the voice quality for these patients. So whilst there are alternatives, we do find that the adhesives are the best possible method of housing the HMEs and also achieving some of the other objectives for voice. Okay, so as clinicians working with this cohort of patients, we do understand the importance of wearing a HME 24/7 in order to maintain that optimal lung function and health. But what is also important is being able to achieve that airtight seal. COVID-19 further highlighted the recommendations within several guidelines and publications of the use of adhesives when using a HME in order to get that airtight seal and also to prevent some of the spreading of bacteria. So whilst we already knew some of this information, COVID-19 pandemic did reinforce the importance of this. So we know from the evidence also that using adhesives compared to other housing mechanisms is preferable. However, here we can see that there are 3 clinical studies that report that there are dermatological problems arising from the use of adhesives. And that can range from 19 to 65% of our patients. So quite a varied number. And looking at the irritation that skin can develop with the use of a prolonged adhesive wear. And another quantitative study carried out in 2019 again confirms that patient skin becomes irritated after wearing adhesives and that the stomal topography impacts on the seal. And out of 1,734 participants, 53% of patients reported that their adhesive came loose or leaked earlier than expected. 50% of patients reported the skin became red or irritated after wearing adhesives. 48% of patients left their stoma uncovered with no adhesive to allow the skin to heal or breathe. And 38% had difficulties getting an adhesive to stick due to the shape or the contour of the neck or stoma. And also 33% had difficulties getting the adhesives to stay on because of sensitive or irritated skin. So whilst, again, we mentioned that this is the optimal way of housing a HME, it does come with its complications. So looking at MARSI, or medical adhesive-related skin injuries, this term is frequently used with our urostomy and colostomy population, and learning from these adjacent fields is also applicable to the field of laryngectomies. McNichols in 2013 had a consensus summit on MARSI with a panel of 23 key opinion leaders and concluded that skin care, including protection against MARSI, is a basic requirement for patient care. The expert opinion presented in the consensus paper did suggest that appropriate selection of adhesive products and proper removal and application techniques can help minimize MARSI. So in 2023, Atos Medical again carried out another market research survey, and this time asked 16,517 patients if they could clarify the problems they were experiencing with wearing an adhesive. And out of this number, 1,882 patients were identified as adhesive users, and they actually responded to the survey. So quite a large proportion of patients. And what they found within this survey is that 41% found that the duration of the adhesive that they were using wasn't as long as they wanted. 36% found that it didn't give an airtight seal when they were speaking, and 14% had skin irritation. Only 9% of them found that it didn't provide a comfortable fit to the stoma. And as part of this market survey, they looked at the relationships between peristomal skin irritation and adhesion or adhesive problems. And the data demonstrated a correlation between those patients who had frequent skin irritation. They also had a lot of problems with getting the base plate to stick. And again, this sort of vicious circle is quite a clear pattern that if you have reduced adhesion, then you'll lead to adhesive problems, and therefore you'll have skin irritation because you may potentially have base plates coming off more quickly than you would like. There were some other factors that came into play with this same sort of survey, and looking at the data gathered, the time since surgery and stoma depth, speaking method, and neck distension during tracheoesophageal speech are significantly related to the problems with peristomal adhesion or adhesives. Adhesive problems are more prevalent during the earlier postoperative years and in those patients with those deep-set stomas. And what this also found is that patients who have a voice prosthesis are more likely to have problems with their adhesive, and even more so for those patients who experience some neck distension during tracheoesophageal speech. So we can see those coming up there. Okay, so some other factors to consider in relation to the frequency of skin irritation are age. And what was found is that skin irritation is less frequent in older total laryngectomy patients. The length of time since surgery, skin irritation is much more frequent in earlier postoperative years. Those deeper set stomas present with more frequent skin irritation, as is the case for patients with neck distension during tracheoesophageal speech. And another factor addressed in the market research was the moisture of the skin. And they found that skin irritation is much more frequent in patients with wet or sweaty or very moist skin. So let's have a look at the medical adhesive technology. So medical adhesives have a layered composition and they have a variety of materials, each with their own clinical benefits. Essentially, there will always be a carrier, an adhesive, and a liner. And some of the factors that we have to consider for our total laryngectomy patients are things like flexibility. So if it's a product that's quite thin and flexible, it might be able to be placed closer to the stoma and more comfortable. However, sometimes for our tracheoesophageal speakers or our hands-free speakers, they require something that has a little bit more adhesives, and therefore we would need something that was a little bit more firm or rigid, and that can give a bit more stability and support. Another consideration when finding the correct base plate is the base plate permeable? So does it allow the skin to breathe and allow for moisture to evaporate and potentially prevents blow through? Or is it non-permeable and traps the moisture underneath the adhesive, which again can minimize the blow through? So obviously if it's more permeable, then it can allow for more blow through, and if it's less permeable, then you'll get less blow through. And then what are the levels of absorption? Hydrogels and hydrocolloids are wound dressing materials and they can absorb moisture. But what that does lead to is a weakened adhesion over time. So again, it's about looking at what do we need for our patients? Do we need something that is more skin friendly and therefore the hydrogels and hydrocolloids are better? Or do we need something that's longer lasting, more like an acrylic base plate? It's also important to consider that level of adhesion. So again, as we were saying, those low tack adhesives are easier to remove from the skin. However, our total laryngectomy patients often require that higher tack level, especially if they are tracheoesophageal speakers. So let's look at the types of adhesives available and see what their features are. So looking at the hydrocolloids first, these are occlusive or semi-occlusive dressings, usually made from gelatin, pectin, polysaccharides, or sodium carboxymethyl cellulose. They're usually covered with polyurethane foam or film on the outside, and they absorb fluids as a result change into a jelly-like mass. They do provide that moist wound healing. They also provide a barrier to infection and facilitate debridement. And this little demonstration just shows where those hydrocolloids would sit and how they function. Okay, so in the Provox Life range, the hydrocolloid base plate is called the Sensitive. It is a skin-friendly adhesive with a synthetic rubber base, and it has tackifiers, or a posh word for glue, to create initial adhesion to the skin surface, antioxidants to prevent aging of the material due to UV light and temperature, and it absorbs moisture. So all the features that we're looking for something that would allow for sensitive skin. So when you're applying the Provox Life Sensitive base plate, it's optimal to pre-warm the adhesive as the material responds really well to this and it helps that initial adhesion to the skin. It is a pressure sensitive adhesive and it does benefit from being massaged onto the skin. And it's also advised that after 15 minutes, the adhesive reaches its maximum adherence. So allowing somebody to keep it on for 15 minutes without voicing will really get that adhesive to stick. When removing this particular adhesive, hydrocolloids absorb fluids, and as a result, they loosen over time. And it might be suitable to use an adhesive remover or water to facilitate that removal. Okay, so if we now look at a hydrogel, these adhesives are water or glycerin based and they're best used for dry wounds. So they're clear and translucent so that monitoring of the skin is easier. They maintain adequate moisture balance by absorbing exudates and bacteria and by rehydrating dry and irradiated skin. It can enhance epithelialization and may decrease some of the wound infections. So again, this little animation just shows how the hydrogel works. And again, this goes back to being mindful of the types of adhesives that are available and what would be the most suitable for the skin that you are seeing presented in clinic. So again, in the Provox Life range, the hydrogel adhesive is called the Night. It is soothing and it can be used both during the day and at night. It's often used for skin recovery, for breached or damaged skin, and it is breathable, moisturizing, water soluble and absorbent. It needs to be applied to clean and dry skin as it is removed with only water. And again, the material readily and easily absorbs water and that loosens it from the skin. So again, being mindful if you have somebody who is particularly sweaty or if they're producing a lot of mucus, this might loosen a little bit more readily than some of the other base plates. And then the medical grade acrylic. So this forms the remaining types of adhesives. These are also pressure sensitive, and the level of adhesion and wear performance of these adhesives are governed by a number of factors. Things like molecular weight, glass transition temperature, and the viscoelastic behavior of the adhesive. Sweating or a moist environment and physical activity are often the cause of these adhesives failing with this type of base plate. So again, we have this nice little animation that just shows how that works. Oops, let me just go back so that we can see that. So it allows for some of that evaporation of the moisture. Again, in the Provox Life range, what we have in terms of acrylic adhesives are the standard and the stability. And these adhesives have a high coat weight of glue and low moisture transport rate, which helps to reduce the amount of blow through during tracheoesophageal speech. They are, again, pressure sensitive and benefit from being massaged onto the skin during application. And again, waiting 15 minutes for that maximum adherence is beneficial. When removing an acrylic adhesive, again, apply the adhesive remover first over the top because the semi-permeable material will allow that adhesive remover to seep through and start to break down the tackifiers or glue, and then use it to lift the base plate from underneath. Some of the factors that we need to consider when we're looking at adhesives, again, is the shape, the size, and the design of the connector. These all play important parts in the wear performance. So with these particular base plates, we have this clover shape with independent movement of the leaves. And they come in 3 different sizes depending on the contours of the neck for the patients that we see. As we know, our patients are not a one-size-fits-all, so we need a variety of sizes to be able to manage patients as they may change or in terms of what surgery they may have had and what their contour looks like. What we find is that the connector is also a factor, and we want to be able to use the base plates to house an appropriate HME. Now, the Provox Life range connector is actually 1 millimeter larger in diameter than the Provox range. And this was designed to be to enable the attaching HMEs to have a 9.6% increase in volume of foam. And what that meant for the range is that this enables the HMEs within the range to be higher performing in terms of both humidification and breathability. Now, the connector has also a secure fit connection, which reduces the blow off of the HMEs and is also a lower profile, so more aesthetically pleasing. The connector is also soft and flexible, and it ensures that there's good comfort. So, if we have a little look at this video, we can have a little look at the range. Oh, it doesn't seem to want to play. Okay, well, we've covered that. So let's move on to the structure and function of the skin. And I'm now going to hand over to Jess.
Thanks, Faye. Hi everybody. So as Faye mentioned, we're going to take a little look into the structure and function of the skin. Um, and depending on your profession, might vary your kind of level of knowledge or your kind of level of interaction with tissue viability over the years. So I think it's really important that we take a look back and remind ourselves of kind of the basic facts and take a little bit of a deeper dive into the skin. And that will just help us to kind of put things into context for when we look through the MARSI categorization later. Okay, so we've got some basic facts which you probably are aware of. So the skin is the largest organ in the body. It renews itself every 28 days, and the thickest skin is on the feet at approximately 1.5 millimeters thick. So the functions of the skin, so there are five main functions of the skin. Protection, and that's against trauma, dehydration, UV light, microorganisms, maintenance of body temperature, sensation, metabolism, excreting the waste through our sweat, and communication as well. So we're taking into consideration, touch, sensory feelings there as well as part of our communication. So the structure of the skin, it's broken down into three kind of main layers. And as I said, it's kind of essential to refresh our memories on this so that we understand maybe why things happen to our patients that we look after. So we have the epidermis, which is the outermost layer of the skin, and that is to trap moisture. And then lower down, we have the dermis, and then the subcutaneous tissue as well, which provides the insulation and cushions for us. So as I said, the epidermis is the outermost visible part of the skin. And again, it varies in thickness across the body. So the eyelids being very, very thin and the soles of our feet being thicker. The functions of the epidermis are barrier function, control of water loss, and protection against UV light, bacteria, and allergens as well. And you can see over here on the right-hand side that it's broken down with all the different names, which I don't think you need to worry too much about today, but it's helpful to have some exposure to the long names that they give the different parts of the skin. So the epidermis is composed of multi-layered epithelial cells. So we've got the keratinocytes, and this accounts for 95% of the cells across the epidermal skin. And it retains moisture and helps maintain the skin barrier's function as well. We've then got melanocytes responsible for the pigmentation and protection against UV damage. And then we've got Langerhans cells, which is part of the immune system. So we'll look now at the keratinocyte differentiation. So keratinocytes are the primary type of cells found on the epidermis, and they constitute for 90% of the skin cells on the epidermis. And what happens is these cells divide and migrate up towards the top layer, so through the stratum spinosum. And these are all kind of the living cells. And as they migrate towards the surface, they degenerate and die, and they now get called corneocytes. So the corneocytes are connected by the desmosomes that make the outermost barrier, the stratum corneum at the top here. And then finally, the corneocytes are surrounded by an extracellular matrix that's hydrophobic. So this is what kind of protects us and makes us waterproof. And also it prevents dehydration as well. So I think this is just a really nice image of how the epidermal barrier is kind of made up. So we have the top part of the skin here, and then we've got all the environmental hazards that come at us throughout the day. And we've got sebum, which are the natural oils that kind of live on our skin. So then we've got this sort of bricks and mortar model, and it's all tightly packed, and we've got the desmomes here, down here, that connect all of these corneocytes together. And then they're surrounded by this lipid matrix inside, if you will, which kind of we present as our mortar to the bricks. So I think this is just a really nice way to break it down to have some vision on the skin. So cell turnover, the stratum corneum is constantly being renewed, and in healthy skin, it takes about 4 to 6 weeks for these cells to differentiate. And the stratum corneum is renewed about every 15 days for individuals with healthy skin. Obviously, if there is some damage, it can take longer. I'm sure you've all had experience with some deep, nasty wounds across your careers. So you can think back to that and think the level of time it took to heal versus someone who is relatively healthy. So as I said, it's a skin barrier function as well. We're still talking about the epidermis here. And, oh, sorry, hold on a second. Oh, okay. So there's some key takeaways here about the epidermis. So the epidermis must be kept intact. The broken epidermis can allow the underlying liquid to weep out on the surface, and the weeping compromises obviously the application and adherence of adhesives. If the dermis is broken, nerve endings are exposed and will trigger pain sensation, and this could be itching, burning, and they are all signs of damage to the epidermis, and it needs prompt action, which is why we're going to look into MARSI shortly. Sorry. So let's go on to look at the dermis now. So this is, if you remember back to that previous slide, it's the middle layer of the skin. And this is much thicker than the epidermis, about approximately 15 to 40 times thicker. It consists of connective tissue, a semi-fluid substance, mainly consisting of collagen and elastin fibers, which, as we know, do kind of degenerate as we get older. And the dermis also contains nerve endings, blood vessels, and skin appendages such as hair follicles and sweat glands. So we have sebum and sweat, and they create an acidic environment on our skin, which is around the 4 to 6 mark, if we're talking in pH. And this is referred to as the acid mantle. And non-healing wounds are known to have a more alkaline pH. And it's been shown that skin heals more rapidly when exposed to acidic environments compared to neutral or alkaline environments. And as we know, the skin is a sensory organ, collecting information via sensory bodies and nerve endings. And the structures provide vital information for touch, pressure, pain, vibration, temperature. So you can understand that if there is some significant damage, then we will experience maybe a reduction in pain, which might cause further skin damage if you're not able to identify those issues early on, which is even why it's so important to keep the skin intact. And the location of the sensory nerve endings are actually a bit deeper, which is why the superficial wounds are often more painful than the big tissue loss that you see with the big open wounds that go much deeper, right down to the subcutaneous. Sebaceous glands, so they secrete sebum, and sebum is a lipid-rich, oily substance which is important to maintain not only the moisture of the epidermis, but also the pH of the skin. The secretion of the sebum is controlled predominantly by sex hormones, and again, this does change with age. So sebum is acidic, and when combined with the lipids, it forms this hydrophobic layer that I was talking about, the acid mantle. And this kind of lays over the skin and helps prevent dehydration, but it also helps to prevent invasion and infection of microorganisms. So now we go to the deepest part of the 3 layers, which is the subcutaneous tissue. And this is as I said, the lowest layer of the skin between the dermis and the fascia. It's a fatty tissue, and it can often be visible in the base of these really deep wounds, such as pressure ulcers or traumatic injury. And the functions of this subcutaneous layer is insulation, cushions, and moisture retention. So we really, really rely on that to, keep us warm and protect us also. So with all of that in mind, I want to just take a look into some of the perspective of peristomal skin relating to medical adhesives. So we can understand that weeping, bleeding from the dermis, from that top layer of the skin, will compromise adhesion to the skin surface, which we've probably all experienced at some point or another, whilst trying to find the right products for our patients. And if the blood vessels are ruptured, bleeding may be visible on the surface. This again is not only going to impact adhesion, it's also going to open up room for, pathogens and bacteria to enter the body as well. So we're going to think about infection as well. So the structures that we've spoken about, the dermis and the epidermis, they could be weakened by suppressive therapy. And this can result in a separation of the layers when removing an adhesive. So this is also called tearing. And this is why the choice of adhesives and the use of adhesive removers is extremely important. Heavy and sudden perspiration. So these, hot weathers, that's really going to impact the wear time of base plates, the overall adhesion. But also the irritation as well. So it's going to really, with all that sweat trapped in between the base plate and the skin, it's likely to cause quite a lot of itching and some further complications. And we can think about maybe changing the frequency of the routine and making sure that we build that into the patient's lifestyle, whatever they're doing. Sebum production, so we've spoken lots about this and this acid mantle, keeping that intact, so that reduces with age, so that is something to bear in mind. Although interestingly enough, as Faye mentioned earlier, skin irritation was actually reported as less in the older population, but it's just something to be aware of. And pulling hairs as well, so if we've got men who are quite hairy, particularly around the neck area, it can cause folliculitis, which is incredibly uncomfortable, can look quite nasty as well. And so it's really important for us to consider shaving, keeping the hair nice and short when we're dealing with medical adhesives. And if the proper adhesive removal technique is not applied, then what we're going to get is we're going to get the skin stripping. So all of that nice protective barrier on the top of our skin is going to kind of get taken away with each rip. Every time they take one off, it's going to get affected. And again, this can lead to pain, risk of infection, and just general discomfort. Not to mention, the psychological impact as well. If they're looking visibly red or they're feeling really uncomfortable, then it's going to impact their mental health as well potentially. So now we get on to Marzi, and we're going to take a look at just some of the different elements that we probably have all come across. I know that I've certainly seen a fair few of these in my time. And we'll take a little dive into each picture, and we can talk a little bit about that. And hopefully this will make things a little bit clearer for you going forward if you're reviewing anyone in clinic. So category 1 is mechanical. So we've got mechanical skin stripping. So you can see that there is a clear defined border where the base plate was, and it's red all over. And that is probably from where they've been removing the adhesive without any form of adhesive remover. And this is where the top layers get repeatedly stripped off, and it becomes very, very uncomfortable. And as with most things, it takes longer to heal than it does to kind of turn up in the first instance. So that's something to bear in mind, to really get their skin routine right before, from the get-go, get them into those good habits right from the beginning. And then that will, hopefully reduce their risk of coming into any problems with skin stripping. So in appearance, the skin may be shiny, it may be red, and as I said, typically you can see exactly where the base plate's been laid. We go next to a skin tear. I've seen quite a few of these in my time also, and this is an acute wound. It's caused by trauma, cuts or scrapes, or skin friction, and it could become chronic if the issue doesn't get addressed. So sometimes it is where, what I find typically is where total laryngectomies, they pick the base plate off from one area, and that's kind of their chosen area to remove their base plate from, and they end up causing these skin tears, which again, it's a bit like paper cuts. They don't look like they should be very painful, but they can be really, really uncomfortable for people experiencing them. Category 2 is dermatitis. So we've got 2 types of dermatitis. We've got irritant contact and we've got allergic contact. So irritant contact is the inflammatory skin response to the chemicals, and it can cause dryness, scaling, cracking, redness, swelling. And I'm hoping that you can see the difference from the previous slide in this picture. So again, it will have typically a well-defined area, but it should resolve with the discontinued use of whatever glue or whatever adhesive they're using at the time, versus if I just pop back one slide, back to the mechanical skin stripping. So you can see the shininess here that I was talking about versus the dermatitis, which looks more swollen, I suppose, is a good way to describe it. It's not as shiny. So there is, once you've got used to defining the two, you do get used to kind of knowing which one's which, as they can kind of be a bit similar sometimes. But I think the shininess is one of the most differentiating factors that I could probably recommend looking out for. And then we've got allergic contact dermatitis. So this is an immunological reaction in an area exposed to an allergen, and it can present itself with small blisters, and it also can spread as well. So like the contact dermatitis is normally located to the point of the base plate. Sometimes if it's allergic contact dermatitis, you'll find that it will spread a little bit further than the area that it's directly applied to. And it might be associated with underlying allergies. So do they have a pre-existing reaction to things like elastoplast and all the typical plasters that we know well? Sometimes you might hear them say that they're allergic to those types of plasters, which should prick your ears up to take that into consideration when fitting them with an adhesive for the laryngectomy. And category 3 is other. So we have got maceration, and folliculitis. So this is where I was talking about our hairy men. We'll come on to that in a second. So maceration. So this is, we all have seen maceration. If we've all spent too long in the bath, we would have, experienced the low level of maceration on our fingers. So it's when we get the softening and wrinkling of the skin. And this happens after prolonged exposure to moisture. So with our laryngectomy patients, this is quite classic when they maybe have a really deep set stoma, so their base plate isn't quite flush to the surrounding, the opening of the stoma. They're coughing, they are changing their HMEs, but they might not be changing their base plate. We can't expect them to change their base plate every time they cough a bit of mucus in, but typically we have patients that will leave it for longer than we would like. And what this does is increases the permeability of the skin and will make it more prone to infection, and again, discomfort. Folliculitis, so this is an inflammatory reaction on the skin around the hair follicles, and it's caused by a bacterial infection. And we can get small elevations around the hair follicles. So like we can see here in the picture, these ones are actually containing little pustules there. They don't always fill with pus. Sometimes they can just be very well-defined red dots. It can be incredibly itchy. It can be hot to touch, incredibly, incredibly uncomfortable. So please encourage our hairier patients to shave before applying their adhesive. So we're going to touch on radiation dermatitis. We won't go into too much detail about this. Radiation is kind of a bigger topic on its own, and we could do a whole separate webinar on that. But there's lots of contributing factors to the skin irritation, such as their topography, but also, the patient themselves, how old are they? Do they have pre-existing allergies already? So the radiation, we've got quite a nasty radiation dermatitis here. And we've got erythema, which is the redness, and it could be dry, it could be moist. So it can present itself in many different ways, and this would require much more specialist kind of input for the radiation issues. Again, aging skin. So we know that our skin becomes more delicate and more fragile as our collagen production is less as we get older. The elasticity is reduced as well as we get older, and the overall blood supply reduces as well. So patient-specific factors, again, like I said, can increase the risk if they have allergies, if they've got a pre-existing autoimmune condition, diabetes, immunotherapies, genetic factors, medications, and stomal topography as well. So we can see here down at the bottom, we have lots of different varying types of stoma in different depths, irregular shapes, and these are the types of stomas that will often require something a little bit additional to get a good seal. But this again, a step-by-step approach, changing one thing at a time so we know what the outcome is. But I think also it's really important to mention here about skin tone as well. So anyone that has a deeper skin tone, the redness is going to appear slightly differently, and things like rashes and all of that will appear different on different skin tones. So that's really, really important to factor in to your assessment. And this is just a little graph in terms of the dermatological issues. They can occur up to 85 to 95% of patients receiving radiation treatment, and it all varies in how long it takes to kind of settle down as well. So signs of erythema, redness, hot to touch, dry, flaky skin, itching, skin thickened, and then we've got moist desquamation as well is a skin breakdown and exudate. So we're going to be seeing some of that kind of clear fluid come through and impact the skin. So we've touched on some of these factors already, but they're divided into intrinsic and extrinsic risk factors, and these are important for identifying patients at risk. So some of our intrinsic risk factors are age, race and ethnicity, pre-existing conditions, underlying conditions, especially those with the likes of diabetes and any kind of venous conditions as well. Peristomal varices as well is something to consider. History of contact dermatitis, late post-surgical ambulation, prolonged hospital stay, a low Braden scale score, dry skin, moderate to severe edema, hypothermia, malnutrition, dehydration. So these are all some of the intrinsic factors to take into consideration. Some of the extrinsic risk factors, drying of the skin due to harsh cleansers, low humidity, prolonged exposure to moisture. So that was our, spending too long in the bath or having that mucus sit on the skin for too long as well. Certain medications such as the chemotherapy medications, steroid use, anti-inflammatories, coagulants, immunosuppressant, radiation therapy, photo damage, so UV light exposure, repetitive adhesive tape removal without using adhesive remover. So we're going to move on to, if my screen will let me, handing back to Faye and minimising MARSI in the total laryngectomy patient.
Thank you, Jess. So we've now had a really in-depth overview of the skin, what its function is, and what it does. We're now going to look at how we can actually minimize some of these problems in our total laryngectomy population. So when we're thinking about sort of 10 top tips of how to, what are the preventable causes of injury to the skin, not choosing the right adhesive for the right patient. So again, this comes back to us looking at what are the different adhesives, what are they made from, what's the component, and what is the aim of that adhesive. Not just to house the HME, but also for the patient's skin contour and also skin sensitivity. And if we don't choose the right adhesive for the right patient, then that will go on to develop some skin injury. If we're not using the proper application technique or removal technique, then those also will contribute to skin injury. If we're leaving those non-permeable adhesives on for too long, that can also lead to injury. And again, repeated adhesive changes, particularly if they're not necessarily required, then you may have increased skin stripping if they're not removing them properly, and that can also lead to further skin injury. Again, as we spoke before, these adhesives do require some time for them to be able to grip to the skin. And if a patient is speaking too soon after application, that can minimize the wear time that they'll get out of it. So encouraging them to have that period of time where they don't speak. And again, if we have mucus trapping underneath the adhesive, that can then over time will loosen the adhesive, meaning it won't last quite as long. If your patients are also using increased speaking pressure to be able to voice using tracheoesophageal speech, then you may find that that also will create some injury because it will lift that base plate. And not supporting the adhesive when removing the HME. So again, making sure that you're giving some support as you're removing that HME so it's not pulling against the skin and potentially causing some damage. And again, touching that adhesive layer prior to application can actually remove some of the tachyphyres, and that will leave areas where it will not adhere to the skin appropriately. So these are sort of 10 of the sort of most obvious preventable causes of MARSI. If we move on to the next slide, what can we do? We can very much help to support these patients to maintain a healthy peristomal skin and then minimize any injuries. It's absolutely within our role to identify the patients at risks, and now that we have looked at the intrinsic and extrinsic factors, we are probably more able to identify these patients now coming into our clinic. And using the most appropriate skin-friendly adhesive option for the patient is essential. So should it be a hydrocolloid, a hydrogel, or medical grade acrylic? We want to ensure that a good adhesive application and removal regime is being used, and the patient is allowing enough time within their regime for this to take place. Maintaining and making intact peristomal skin a priority and regular monitoring can help us to detect those problems really early and ensure a timely treatment. And the bigger picture of that is that you still maintain really good HME compliance, which is great for lung health, because if people are not managing to keep their adhesives on, then they won't be able to wear their HME unless they're using something alternative like a tube or a button. So, if we have patients who are prone to or have risk factors for MARSI, then consider using a skin-friendly hydrocolloid where possible. And in a study by Hirans in 2001, they found that fewer patients experienced skin irritation with hydrocolloids compared to the acrylic adhesives. And having now looked at the properties of a hydrocolloid and what their function is, this would make perfect sense. Okay. And sometimes it might be also necessary to use a hydrogel adhesive at regular intervals to maintain that skin integrity and also help the skin to recover. And in a study by Ratnayake, I think that's how that's pronounced, apologies for that pronunciation, in 2019, they found a significant increase in the mean days of skin improvements when using a hydrogel adhesive during the night, and an increase in the number of hours of HME compliance. So again, this hydrogel can also be used to recover the skin as well as being used overnight. But again, it's being mindful of the patient type that you're picking the hydrogel for, and ensuring that it's going onto a dry surface. So one of the biggest impacts on skin health is the meticulous application and removal technique that we use for these adhesives. And I think in the poll that we had right at the beginning, the majority of people who have a patient come to their clinic with some skin irritation would look at this as a first port of call. Now, allowing time for each of the 4 steps can significantly reduce the amount of skin stripping that can contribute to MARSI. So again, we'll just sort of recap this. If we're looking at step 1, we're removing the adhesive. We want to slowly and carefully and gently remove the adhesive, starting at the finger lift tab. And on the adhesives, there is a little tab that you can get under that helps you to be able to lift that adhesive off. It's ideal to use the Provox adhesive remover or water for easy removal, and remove at a 180-degree angle, and also supporting the skin at the same time so that you're not pulling on the skin, you're giving it a level of support. Step 2 is then to give it a good clean. So you're wanting to clean the skin using a cleaning towel or with soap and water and let it dry. It's important to let it air dry and so that it's completely dry, because otherwise when you come to apply your adhesive, it won't stick to the skin properly. It's not advised to use abrasive soaps or cleansers, which is often why water is the choice of the preferred choice. But if you're using any soap, then make sure that it's not abrasive or it doesn't have any sort of chemicals as cleansers. And again, when you're cleaning the skin, you don't want to use any creams or ointments or moisturizing soaps, because they do leave a residue on the skin, and that can then prevent the adhesive from sticking to the skin. Step 3 is to apply a skin barrier. There is quite a lot of evidence out there to support the use of skin barriers. It's certainly relevant in a number of different sort of skin management guidelines. And if you apply the skin barrier, obviously, unless it's a hydrogel, because obviously with the moisture, you don't want anything in between the skin and the hydrogel. But you want to apply that to the entire area that your base plate will cover. And again, allow that to dry completely. So again, that's why this application and removal technique takes time, and patients do need to factor that into their routine. Once that's completely dry, or at least whilst that's drying, you can pre-warm the adhesive, especially the hydrocolloids, as we know that these benefit significantly from being warmed. And once you've warmed that and it's started to activate the glue or tackifiers, then you want to apply the ring as close as possible to the opening of the stoma. Then it's important to massage the adhesive onto the skin. Because as we know, these are pressure sensitive adhesives and they require some level of massage onto the skin for them to adhere properly. Give it time to set. So as we've talked about before, about 15 minutes or as long as you possibly can, up to 40 minutes with no voicing, just to allow for that tackifiers to seize against the skin. And that is how we would like the patients to be able to apply and remove those base plates. So what do we have here at Atos? At Atos, we have some great resources for you in order for you to either use yourselves or to give to your patients. And these are our care tips, and they give a really good demonstration of how to correctly apply and remove the adhesives, and also provide some tips and tricks to get an airtight seal. And the QR code that's on here will be available for those who would like to download and use the care tips, or you can get in touch with us here at Atos and they can be sent out. Okay, so looking at some tips and tricks, which are always helpful. So in order for us to try and extend that duration of that adhesive seal, there are a number of things that we can try. And developing a really comprehensive adhesive change schedule that fits the individual patients is really important. Factoring the time that it takes for each of those steps to be completed and then allow for drying, it's quite important. What we want to avoid really is sort of ad hoc adhesive changes unless they are absolutely necessary. Some patients will routinely change their adhesive every 24 hours, and that's fine, it's part of their regime. But if they're removing it unnecessarily in between, then obviously that can potentially impact on their skin. So allowing that plenty of time for that meticulous removal and application, and also getting it right the first time so that that seal lasts all day. We don't want them to be sort of putting it on rapidly and not taking those steps and then having to redo the whole process again in a few hours' time. Again, ensuring that that skin is clean and dry and free from any creams, ointments, or adhesive removers. And again, warming that adhesive by rubbing it either between your hands, some people put it under their arm, in between their legs, under their bottom, anywhere that will warm up the adhesive and activate that glue. Again, trying not to touch the sticky layer because then it removes some of the tackifiers and it means that you will have a patchy adherence onto the skin. And applying the adhesive with the neck in a neutral position. So if you stretch up the neck, then obviously when you then bring the neck back down, that can impact on the seal. Always good to start from the center around the stoma and then work outwards, starting with the bottom and then the top and then the sides. And again, as we know, they're pressure sensitive, these adhesives. So again, you're wanting to put quite a lot of massage into that to ensure that A, there are no gaps and wrinkles that can allow any moisture or mucus or air to trap under it, but also then to make sure that you've got a complete adhesion to the skin. And also then letting it set. So again, allowing 15 minutes of no talking, relaxing, just to get a really, really good seal. And also, don't forget that obviously when they're talking, your patients, we want them to try and speak without too much force. The more force that they're putting on speaking, the more that base plate can lift and pull at the skin. If your patients are going to be coughing, try and encourage them to remove the HME by also supporting the adhesive with 2 fingers and then removing the HME, and then also removing any mucus after they've coughed so that doesn't sit underneath the base plate and start to loosen or lift the base plate. Again, removing the adhesive, take plenty of time. Make sure that this is a really gentle and slow removal process. Again, getting the angle right, starting at that finger lift tab so that we're not just pulling it off like a plaster. And these routine or tips can actually help to achieve that really airtight seal, and hopefully that will have a positive impact on the patient's speech and also minimize skin irritation. If you do notice that the skin begins to look red and irritated, again, give it a chance to rest and recover, but perhaps not by removing the base plate completely, but by using an alternative like a hydrogel or a hydrocolloid if they're not using that already. And they might do that just overnight or maybe when they're watching television. Again, having that regular good schedule for the use of the hydrogel adhesive, obviously it can prevent intermittently to get such irritation of the skin that they stop using a base plate. So there are lots of ways to try and manage this. It might be that every night or every other night or twice a week, they actually use the hydrogel to help with that. So I'm now going to hand over to Jess.
Thanks, Faye. So we are going to just touch on the new skin assessment tool that we've developed here in the UK. Again, hopefully if I can, here it is, move on a slide. So we have, as I said, developed a skin assessment tool and management tool. So this has been developed by head and neck nurses who have a tissue viability background also. And this is a in-clinic poster. It's kind of to facilitate diagnosis and management of skin conditions in our total laryngectomies. But hopefully we also hope for this to kind of help standardise assessment across up and down the country and communication with clinicians as well. So that we're kind of all on a similar page and we all have a really nice central point to kind of guide us through the management of some of these different skin conditions. So as Faye touched on, you know, it's directly correlated that, you know, it can have an impact on pulmonary health and the ability to voice if they are experiencing skin issues. So we hope that this would be really useful for you guys. And if you would like to obtain a copy, please reach out to your territory manager. Hopefully you all know who that is. And if you don't, please just drop one of us an email and we can guide you in the right direction. So now I'm going to hand over back to Faye, I think.
Thanks, Jess. And we hope that this has been a really beneficial webinar, just raising awareness of different skin conditions. All of the information that we've given you today is based on the white paper, Peristomal Skin Health, the Foundation for Successful Voice and Pulmonary Rehabilitation. And if you are wanting a copy of the white paper, which goes through all of the topics in a much deeper dive than we've covered today, then please do reach out, or there is a QR code on the screen at the moment. But I'm now going to hand over to Claire, who's going to field some questions.
Thank you both for that. That was very interesting and informative. I find it so interesting talking about skin because I personally have quite a long skincare routine, but I think if we think of our typical over 60 male laryngectomy patient, they perhaps aren't quite as interested as some of us in spending a lot of time on the skin and making sure that the routine is correct, but it will result in much better base plate sticking and comfort of the skin, particularly like the hydrogel, which I always like to think of as a bit like one of those tissue masks, and allowing your skin to sort of get some extra moisture. Jess, don't you agree? And just
Yeah,
give
I
it a bit
do.
of relief, not necessarily at night, maybe just in the evening when you're watching telly. But again, sometimes that is a little bit challenging, getting our male patients to come on board. Do please add any questions under that little question mark tab at the top right of your page. But we're really pleased that we had a couple of questions come in ahead of time. So thanks to those who added those questions when they registered. I think a couple of them we've addressed during the webinar, but we'll just go through them to just pick out those finer details. Jess, I think this first one is for you. So can soap and warm water be used safely to clean the peristomal skin? And can you just use plain water and allow it to dry? Is there any evidence that you know of about using soap and water on the skin?
Yeah, so I think Faye mentioned earlier that nothing too abrasive, and you can get soaps with all sorts of different moisturizers and different ingredients with it. So I think if you are going to choose to use soap, have it to be something very, very natural, something like the simple ranges that's not moisturizing, something very simple. So you can use soap and water. I think, we've touched on it as well. One of the most kind of common errors that I certainly come across in patients' houses is that they will, they'll go, oh yeah, the skin routine's great. I use the adhesive remover, I use the barrier, but actually they are missing out this really vital step of cleaning the skin with water. So again, it depends on what sort of base plate you're using as to kind of how much tackiness is going to be left behind as well. But never ever skip this step, I would say. I don't know, I couldn't really comment on specific evidence for and against today, but both are acceptable providing you're using the right type of soap. So nothing too perfumed, nothing too strong, just very, very basic soaps. And as Faye mentioned earlier as well, allow it to dry. Really, really manage your patient's expectations. I always find that people that are able to take on a bit more information kind of pre-surgery or during the hospital stay post-surgery, they tend to do so much better when they get home because they've been given this sort of their expectations have been managed. They've gone from being able to speak at will and being able to get up and get dressed and leave the house without having to do anything, to now having to really think about this crucial kind of routine that they need to factor into their lives. They may not have had to really factor in any specific sort of self-care into their lives at all until now. So really do all you can if you're in clinic with these laryngectomies. Really try to manage their expectations that we need time. You need to factor in that time to allow it to be removed and cleaned properly. Yeah, I think that would be my biggest bit of advice in terms of water versus soap. Doesn't really, whatever your preference is, I think.
Yeah. And is it sometimes a bit of a trial and error as to what routine and what products are going to work for your skin? So you might
Yeah,
try one soap, for example, and that's causing some sensitivity, so you might try something else.
yeah. I think one thing I always say, particularly to the people that we visit in their house is, you know, change, if you can, change just one thing at a time. Give that a solid amount of time to work, because what we do is we tend to see, right, well, that's not working. Let's just change everything and let's hope for the best and hope that this new routine works for you. But actually, stripping it right back to the basics. If you have to, take it all away initially just to allow that skin to heal and recover fully, then that's what you have to do. And then build from there. So build in a step at a time. It does take a little bit more time, but I think it is a much more effective system. Again, as long as you've managed your patient's expectations with timeframes and stuff, because I think that's where the frustrations can come in, and then we see them going, oh well, whatever. I'll just put a base plate on. I can't be bothered. But actually honing in how important all of this is to save them in the long run from
Mm,
potential admissions if they let it get that bad, to just generic discomfort on a day-to-day basis. So
mm.
yeah.
Thanks, Jess. Um, I'm afraid the questions are all going to end up being for Jess, but I'm going to let Faye have a stab at answering this one. A question that's come in
That's
on
okay with
the
me.
question tab. Um, is it better to use the night base plate or just for a patient to use a Larry tube or button with neckties to let the skin heal? Happy for you to hand that over
Um,
to Jess.
Yeah, I think that this probably will be a better one for Jess to answer. I would say it will depend on your patient, for one thing, because obviously looking at what that night base plate is, it's hydrogel, and you want to make sure what you want to identify what the difficulty is. And therefore, if they have very moist skin or they have a lot of mucus, then the hydrogel might not be the most suitable, particularly at night, as it may move if it loosens. But again, so that it might be then that that's more suitable to have something like a Larry tube or potentially the sensitive if they're not already using that during the day. But then I'll hand it to Jess, so he'll give no doubt a very comprehensive answer.
Can you just repeat that question for me, please, Claire?
Yeah, is it better to use the night base plate or just to convert the patient to a Larry tube or button?
Yeah, so as Faye quite rightly said, it's going to be very much on an individual basis first and foremost. It depends on, are they currently struggling with skin issues, or are they, you know, bumbling along quite well and there's no kind of real concern. Um, Again, are they suffering with stoma shrinkage? Are they not? There's so many things to take into consideration with nighttime products and usage. And I think that, we kind of go back and forth between, should you remove your daytime base plate and put a nighttime one on, or switch to a Larry tube? Or if your base plate's lasting, could you just wear that all night long? So I really would recommend, knowing your patient, you know them, you see them face to face. You kind of get a good feel for their routine, and who they are and what they're currently experiencing or struggling with. Um, but the night-based plate certainly has its place. It's not just for nighttime, as you said earlier. I remember really well putting a lady on a nighttime base plate all the time because she just couldn't tolerate anything else. She was too sensitive for a Larry tube. She'd just choke with all the different lengths and sizes until she'd end up, eyes are streaming, nose running. We've all seen that before. So she couldn't tolerate a Larry tube or a Larry button. She loved base plates. It gave her a really good voice. So we had no option but to go on to the hydrogel because it was what was kindest for her skin. Luckily for us, she wasn't very hairy. She didn't sweat very much, so she did get a good enough, seal to produce a good voice. But I think I would just probably recommend deep diving into your patient's current routine and struggles and taking it from there. I wouldn't say one is kind of better than the other. It depends on the specific needs of that patient.
Mm.
Yeah, I
And
think
like you're
everything
both
has a
saying,
place.
sorry,
Sorry,
Faye.
Mm.
yeah. Everything has a place, doesn't it? There's a place for tubes and buttons, and there's a place for adhesives, and it's what works for your patients. I think there is, or potentially has been, a school of thought of, oh well, if your skin gets a bit red, take it all off and let it heal and breathe. But again, it's looking at the underlying cause of that. Is it down to mechanical stripping? Is it down to, this is where your skin assessment tool comes in really, really handy, because you can identify what the cause is. It might be that actually it's part of the regime, that they're either missing a step or not taking long enough over a step that's causing that
Mm.
skin irritation. And if we can nip that in the bud, then they may not develop a period of time where they need to remove their base plate for allowing that skin to heal. So again, that I think this is where the skin assessment tool for, particularly as a speech therapist, is really handy, because I'm certainly not a tissue viability nurse. I only know what I see and I manage it the best I can. Whereas now you potentially will be managing it in a more informed way. So again, that's going to be a really useful tool.
Mm. And I always remember in clinical practice, you might think that a patient is having a reaction to one of the adhesives, and I have to say I didn't really know how to manage that as a speech therapist. But I remember, Jess, when I joined Atos, one of your nurses told me about just cutting a little strip of all the different adhesives and popping them on the neck to see
Yeah.
which, as a quicker way of breaking down which one actually suits the skin. Just with anything that we're trying on our skin, you do need to try lots of different options, and everybody's individual as to what will suit them. So a linked question to that also came in ahead of time. What would you do if a patient can't manage? So we're saying that the sensitive, the hydrocolloid is the most skin friendly adhesive, but if a patient is reacting to that, what could you do?
So I think, I touched on it. Considering a hydrogel, again, that comes with its own considerations and potential problems. If we're talking about, quite a large, sweaty, hairy man, it's probably not going to stick very well. It gets removed with water. That's how the adhesive works. So you're definitely going to have to pick your audience with the hydrogel. But I found that to be really, really effective in people that struggle with the sensitive kind of hydrocolloid range. Um, Obviously, if you're talking about just our sensitive range, there are other hydrocolloids out there. You could try that. I don't know whether that would be a bit of trial and error. But I think that, if they're not able to tolerate the sensitive range or a hydrogel, I would probably lean towards it's probably an allergy um, kind of situation we've got on our hands. So I would probably consider moving on to something like a tube or a button or something that is, doesn't require adhesive at all. Certainly move on to that to allow the skin to sort of heal in its entirety, and maybe you could revisit it down the line. But interestingly enough, I've seen many people that kind of get on with one routine and then they go for treatment and they go through radiotherapy and then their needs completely change. But I mean, that's even in terms of using Larry tubes, the amount of kind of sensitivity that seem to develop is really interesting actually. It's something I've always found
Mm,
quite fascinating how things can change. So again, how long have they had the laryngectomy? How have has things changed as they've got older? Have they developed more comorbidities as they've gotten older? So there really is so much to kind of take into consideration. And I think sometimes when we're busy clinics, busy wards, environment, you've got 101 things to do throughout the day, we can forget that quite easily sometimes, to kind of take a step and stop and pause and think, right, it is always multifactored. It's very rarely going to be just one thing, and it's very rarely going to translate across every single patient either, because they're all going to be so individual. But I think also just touching on skin sensitivity as well. I know that if you're seeing them in clinic, you're not necessarily going to have that insight, but consider their home environment. Do they live in kind of not very optimal conditions? Do they have their heating on full whack all the time? Do they not ventilate their rooms? That can be a huge, huge contributing factor.
mm,
They're always going to turn up to their appointment, in the best shape possible, having a fresh base plate on and a nice HME on. But in reality, we find that that's quite often not the way when they're in the safety of their own home, but actually the warmth and the kind of lack of ventilation just contributes to skin sensitivity. So it's kind of thinking outside the box a little bit as well when you're only seeing these people for sort of half an hour in clinic or so, and kind of those other factors that happen when you're not around. Definitely take those into consideration. But yeah, I think it's difficult when you do have a patient that is, having allergy issues and persistent issues. Um, but again, as I always say, strip it right back to basics, figure out step by step what is going on. Is it actually the adhesive, or is it maybe their skin prep, or is it, many, many things to consider. So strip it right back and start to build up again.
mm. That's really valuable. Thanks, Jess. And I think if those in the audience, if you haven't tried this before, just wearing an adhesive yourself for a day against your skin. I've tried it on my forearm, and then removing that adhesive. You can empathise a little bit more about how sore it actually can be having to wear something next to your skin all the time.
Mm.
So that just shows how that really careful removal, even though it seems to take a painfully long time, makes a significant difference. You know, if you've got 10 minutes to change a voice prosthesis, you know, do you want your patient to actually remove their adhesive um, in the bathroom in the waiting area rather than you going, come on, whip it off, I haven't got time, you know, just to prevent that sort of stripping skin injury.
Also, Claire, I think,
Radiotherapy. Oh yeah.
sorry, I was just going to say on the removal thing as well, you know, don't be afraid to use more than one. Whichever remover you're doing, they normally come in, you know, sachets of some effect. And don't be afraid to just use 2 or 3 if you need to, because they can dry up quite quickly. And I think people go, oh, well, I've used one and it's, you know, I rubbed it around the top and that's enough. But really, really, you know, peel it off with the remover as much as you need is something to
Mhm.
consider as well.
And if it's a patient that's worried about using lots of different products, then like we've said, water, you can use water
Yeah.
to help remove. We've talked quite a few times during the webinar about radiotherapy, and Jess, you even said it's a webinar in itself. So I'm going to make a shameless plug for our radiotherapy webinar, which is at the end of this month on the 27th of September. And Mary, our events guru, is very kindly going to pop that into the chat. There it is. So if any of you want to explore the topic of radiotherapy a little bit more, so we will be touching on the skin, but also just on general routines during radiotherapy. What's the speech therapist role? We'll have a patient example in that webinar. So do register for that, and remember that if you register for one of our webinars, you get sent a recording. So even if you're not free at the time, you can catch up later. But if there are no further questions coming through from the audience, then we're going to wrap up now and let you all get on with the rest of your days, finishing up a bit early, which is always a great thing. But thank you everyone for joining us. Any questions, please do get in touch. If you suddenly think of a burning question in the night, we'd be very happy to ask Jess and her nursing team to answer. And don't forget that the head and neck nurses at Atos often get referrals for patients that have got issues with their skin and managing a base plate or adhesive. So do consider referring to the Atos care nurses for their expert input. Thanks very much, everybody, and hopefully see you all soon.
Thanks, guys. Bye.
Thank you.